Actually, can I make a request? What do you think? Is it a little bit warm in here?
Yeah, it is.
Can we get the hotel to spend a little bit more money on the air conditioning? We warm up the planet a little bit more. Yeah, much cooler. Yeah. My talk will go slower if it's warm. The engine, it doesn't work so well. The brain. Okay, so you all know that I have, a patent on this Presbyond thing, which is interesting because it's only now that the Presbyond is starting to take traction, right? Whoops. Oh, it's there. Okay. Where's my phone? Where's that thing? Oh, there. So it's only now that we're starting to get traction. And it's been going on for 20 years. There's nothing new about Presbyond. But I'm excited that people are taking interest in it now. And I believe that one of the reasons why we're taking interest is because the lens companies have gone through the whole cycle of, zeroing out the spherical aberration, diffractive optics, improved diffractive optics, and finally EDOF. And EDOF is Presbyond. So finally, the people who were believing that lens surgery was the right solution are using EDOF lenses, and then we now say, well, that's what we were doing 20 years ago on the cornea. So what I'm going to do is I'm trying to run through the theory of Presbyond, and then we're going to have a long session on all the discussion about this. And the observation that I've had over the last 20 years is it's like a dysfunctional marriage, where the couple are talking at each other, but they're not listening to each other. And it's like the clear lens exchange people and the corneal Presbyond people are it's like two different planets. And it's like different languages, and it doesn't matter, they're shouting at each other, it doesn't work. Actually, over the last 20 years, I've discovered it's not two planets. It's three planets. And it's actually not cornea versus lens. It's actually multifocality versus spherical aberration-induced EDOF versus monovision. Those are the three planets. And you can do any of those three either on the cornea or the lens. Now, let's talk about multifocal corneas. And this is where the confusion and I think the prejudice against corneal correction of presbyopia has come. I'm going to go through a literature search that we've done on all of the multifocal corneas, and I'm going to explain the optics later. But I just want to show you this search which we've done. It goes all the way back to 2004. And if you look here, we have the 20/20 rates, the J1, the J2, and the loss of two lines and the contrast. And obviously back then, the results were really quite poor. Low contrast, low efficacy, and lots of safety issues. From 2012 to 2017, things did not improve. And from 2017 until the present, things still did not improve. You see, multifocal corneas are not the same as Presbyond. If we look at now the literature review of Presbyond publications and multifocal corneas, and these are the number of studies, READ is a subset of Presbyond now. Before, it was a multifocal cornea for myopia and a EDOF spherical aberration for hyperopia. But if you look at the results, and this is all of the studies put together, you see that, and remember that Presbyond treats myopia, hyperopia, and emetropia. READ only low hyperopia. Presbymax does all three, and Supriya does all three. The near vision results are pretty much the same for all the treatments. but the distance vision results are very different. Remember that Reed is only low hyperopia, but Presbyond gets excellent near and excellent distance for all types of vision, whereas the multifocal corneas do not get good distance vision. And the safety is very poor for multifocal corneas, but it's excellent for EDOF spherical aberration, which Reed is a subset only for low hyperopia. So if we look at the cross-section, these are just diagrams of what these profiles look like. When you have a multifocal cornea like the Schwinn Presbymax or the BNL Supercore, you have a central steepening zone. With Presbyond, it is a smooth aspheric surface. And of course, Reed no longer does myopia. It used to be called Q-slider surgery. And the Q-slider in a myopic treatment is a problem because you are trying to make the center steeper when you're flattening the whole thing to treat myopia. That means a central island, so it ends up being the same as Presbymax and Supercore. Now, Alcon's Reed for hyperopia, low hyperopia, is also a smooth surface because the negative Q works out the same way. But making a negative Q on a positive, an oblate surface, it doesn't work other than to make a central island. These are actual topographies that you see at the end of a Schwinn low myopic and a Supercore low myopic treatment. You have a central island. With Presbyond, it's a smooth profile. It looks normal. It looks like a normal treatment. And of course, Reed doesn't do it. With the hyperopia profiles, you actually have a super little nipple in the middle of the hyperopic profile, a very small optical zone with Presbymax and Supercore, but Presbyond is a huge, beautiful, big, beautiful optical zone. And actually, Reed is similar because it's a hyperopic ablation, giving you negative spherical aberration, negative Q. So you see, multifocality in the lens or the cornea has a high chance of night vision disturbances, low contrast, and reduced tolerance. And retreatment options are quite limited in the cornea because it's a weird cornea. So now let's look at monovision. The disadvantages of monovision are, of course, no intermediate vision, loss of distance vision because of visual confusion between the eyes, loss of stereo if the monovision is more than 150, loss of summation because you don't have two eyes summating to give you better binocular vision, and the poor tolerance, which you have to do a contact lens trial for, and it's a lot of extra work. Well, when you use spherical aberration, you change the disadvantages of monovision, because in monovision you have to choose intermediate or near, but you can't have both. But if you use spherical aberration, you can increase the depth of field. It is not a multifocal cornea. It is a smooth, continuous optic. And so many times people say, well, what's spherical aberration? Finally, we're going to explain what spherical aberration is. Basics. If you have an aspheric lens, Nikon, Zeiss, high-quality optic, what it means is that the incidence of attack of the light at all distances from the center is the same. So you have the same angle of incidence, therefore you have the same focal distance. That means that everything is focused at a single point and the quality of the image is very high. If you have a spherical lens, right, a sphere, then the angle of incidence of light is not the same. In fact, it increases the further away you are from the axis. And this means that central rays are focused further away than peripheral rays. They're focused closer. That is spherical aberration. What it does is it stretches the focus, and that becomes a depth of field with lower quality of vision. Now, the influence of spherical aberration in optical science would be that it decreases quality of vision. And all the optometrists 20 years ago, when I was presenting this, were optometrists PhDs, Pablo Artal, all these people were saying, you can't do that, Dan, because you're going to get low contrast. And I was saying, no, it doesn't work that way, because the brain is taking an image on the retina that is spherically aberrated, but the brain is making it look sharp in the mind. There is a filtering going on. If this wasn't the case, LASIK would have never worked, because we are always increasing the spherical aberration of every single eye we operate on, and we don't have most of the patients with night vision disturbances. That's because we have, as humans, can filter spherical aberration. There's your spherical aberration. So this is presbyond. So the near eye is focused at minus 150, and the distance eye is focused at plano, but there is a 1.5 diopter depth of field around each target. Now that means that the distance eye sees at distance as if it was minus 0.75, which is 20/50, 20/60, and at near it sees as if it was minus 225. That's 1.5 diopters around minus 150. Whereas the distance eye sees at near as if it's minus 0.75, because that's 1.5 diopters around plano. And because both eyes are minus 0.75 at one or the other distances, there is fusion. There is enough information in the near preferred eye that the brain can fuse the images from the two eyes and create stereo acuity and binocular vision. This is different from monovision, where there is no depth of field, and you have two images that the brain has to decide which eye to look through, but it has to suppress the other eye because the vision in the other eye is too blurred. So blended vision is not the same as monovision. So anybody who says to you that presbyond is just monovision, you say, no, it's not. It's modified binocular vision. And the proof is that stereo acuity is preserved. So when you look at the defocus that occurs with sphere, you see that when you get to minus 150, there's too much blur to see the letters. But if you take the same minus 150 and add spherical aberration, you're stretching the focus, and now your brains, right now, your brains are detecting the edges because there is a spherical aberration modification of the edge which you can filter. So when we think about why presbyond is binocular, it's actually better than this because it's not a spherically aberrated distance eye and a spherically aberrated near eye that the brain has to join. The brain improves the image in here, up here, from what it is on the retina. So actually the brain is only putting these images together. That's why the tolerance test, the plus 150 test, which is an exaggeration of the final result, is so reliable. And that's why with a 3-minute extra test at the end of refraction, you determine if someone's a candidate or not. And 95% or more of humans are candidates. So in this room, only 3 of you are not candidates. And the rest of you, with your glasses, you're having presbyond. Okay? So it's everyone. That's different from monovision, where you're trying to, well, you can't marry those two images. They're too different. All you can do is have alternate suppression, which is monovision. So again, the defocus is improved by spherical aberration. Remember that when we accommodate, even if you're 70 years old, you have meiosis. And meiosis increases the depth of field also. Well, you don't have meiosis if you have a lesion in the Edinger-Westphal's nucleus, or if you have an Argyll-Robinson pupil, or if you have diabetes with a third nerve. But apart from those, you get meiosis. And so therefore, the actual retinal image is better than expected, and then the brain does the filtering. So you see, I'm standing here in front of you with minus 175 in this eye, but my visual acuity is about 20/50. No minus 175 off the street in the virgin eye is 20/50 with a minus 175. I have much more distance vision than expected for the center refraction. The results, you've seen this slide 100 times. These are the original publications. Myopia up to -8, hyperopia up to +6. We have 98% 20/20 J5, 95% 20/20 J5 with hyperopia, and the emmetropes, 97% 20/20 J5. It's an incredible accuracy. Why? Because it's LASIK, and LASIK is very accurate. Much more accurate than IOL calculations, even if you're using the EQ, blah, 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 blah. The lens calculations are not accurate because we don't have the ELP. The elephant in the room is the ELP, and we don't have that sorted out. Of course there's no loss of two lines. You know why? Because it's LASIK. There's no loss of two lines. There's no central island. There's no bumps. And stereo acuity, which we tested, is preserved. So there's no loss of stereo acuity, and in fact, there is uncorrected stereo acuity, even though one eye is really a distance eye, because there is enough information at close that there is still fusion and stereo acuity. My stereo acuity is 40 seconds. And I'm 62. I have no accommodation. Well, I have a little bit of accommodation, but very little. But I have binocular vision, you see. And this contrast actually tends to be higher on average, not clinically significantly, but statistically significantly, because we're optimizing the depth of field of the eye, and we have binocularity. Now, most new technologies, when they're launched, like, I just came back from South America, there was a whole session on the galaxy. Everyone's so excited about this spiral optic, and I'm excited about the spiral optic, because it sounds pretty wacko. Spiral optic. What? Well, we went to this whole session. You have 5 people speaking. There isn't one peer-reviewed publication on that lens. Not one. So we've reached a point in refractive surgery where the companies think we are so stupid that they can market lenses that they like, you've got to put this in. Why? My patients are happy. Without any published evidence. Like, not one. Like, could you have at least published one paper before you start pushing this into humans? No, because you don't need to. Because surgeons are like lemmings. You tell them what they do, they all jump off the cliff together. It's infuriating that we've now reached a point where they believe that we are not critical thinkers. And we are. So Presbyond, let's say it's launching again. We have 18 publications in the peer-reviewed literature from all over the world, including one, my most recent one, which was in 22 commercial pilots. These are people who have to see in extremely difficult conditions, dark, haze, rain, fog, at night, and they have 7 distances inside the cockpit. So they have to have 3 pairs of glasses to be able to see 7 distances, because 2 glasses doesn't do 7 distances. It does 6 if you have trifocals. These pilots made a questionnaire of all of the difficulties that they're having as presbyopes. And after the surgery, the same questionnaire demonstrated that we fixed the problem. Most of these pilots were flying without spectacles any of the time whatsoever. And that's not something that you can get with an IOL calculation, and certainly not if you put a diffractive or a refractive multifocal in the eye. These are the results from the literature, and you can see that practically all the centers around the world are getting the same results. 20/20 rates in the 90s, and J3 rates in the high 90s, very good accuracy, and very low enhancement rates. Now, the first two papers that I published were 20% enhancement. You know why? Because it was a Hansatone. And when you use a Visumax, you're making an even flap that has no cylinder effect and very little sphere. Sometimes you can get a sphere and cylinder effect from an irregular microkeratome flap. So our enhancement rates are 9% for everybody we treat, like from +6 to -8, including plano presbyopes. It's only 9%. Now, two of the studies that I want to highlight here, one is Sriganesh's study, where they showed near 100% independence from glasses in myopes and hyperopes, and near 100% satisfaction with 0 dysphotopsia. Same with Andrea Russo, near 100% satisfaction for myopia and hyperopia, near 100% spectacle independence, and near 0 dysphotopsia. So, if you're talking about, let's say, giving a patient freedom from glasses after developing presbyopia, the EDOF-based increased depth of field is the best static solution we have to solve the loss of the dynamic process called accommodation. All of the solutions up to date are static solutions to solve the loss of a dynamic process. But John Marshall said something very interesting in 2013 when I first presented this at ACOS. He said what Dan seems to be doing is transferring the loss of the dynamic process in the lens, and he's transferring that to the brain, where the brain has a dynamic process of filtering through the spherical aberration to give increased depth of field with a static optic. It's an interesting way of looking at it. Also, Sri's group with the only, I think it's the only effective reading speed objective measurement test, the Salzburg desk, this is really strange. They had faster reading speeds after Presbyond than they did before Presbyond with both eyes corrected for near. Now, we're not sure whether it's they memorize the text, they're geniuses, they're actors who know how to memorize text, I don't know. But perhaps it's to do with prismatic effects in glasses that might slow down the tracking of the eye as the image moves off or something, who knows. But this was 30 patients where they found that the reading speed was higher. You have a comment?
Yeah, because they were using progressive glasses, and then they had to adjust they lift their chin and adjust the angle before they could read. And that took time.
That takes time.
That takes time.
So, let me just finish with the story. So, we have presbyopia, and presbyopia, okay, SMILE is a great procedure, we love it, but those are young people. And in Korea, you have a shrinking first generation, and then you have this pyramid going up. So we have this argument between lens and cornea. Let's do the Socratean technique of finding a place where we agree with each other. And when I say agree with each other, I'm talking about clear lens exchange versus corneal refractive surgery for presbyopia. I'm not talking about cataract surgery. Cataract surgery is cataract surgery. You can't fix cataract on the cornea. So we all agree about that. But let's just say that accommodation is still available until you're about 60, maybe a little bit more. And so if you're taking out someone's lens when they're 52, and then maybe they have 2 diopters of accommodation or 1.5 diopters of accommodation at the age of 52. And then you put a lens in that has 1.5 diopters of accommodation, of depth of field, well, you haven't done them a favor. You've just put them at risk. So accommodation is still present. Let's just say that we could predict the formation of cataract in the next 5 years, which we can't, but let's say we can. Well, somebody in their 40s, they're not going to get a cataract in the next 5 years. Come on. In their 50s, maybe. In their 60s, Probably. In their 70s? Yeah, okay. Retinal attachment. Now this is not discussed, and I've been talking about this for 20 years. The ESCRS is finally doing a prospective study, which was sponsored by the ESCRS Research Fund. Oliver Findle presented the results last year, and he said and found that if the axial length is 25 millimeters or more, and you're male, and your vitreous is attached, within 3 years, you have a 10% chance of a retinal detachment. I don't think that's included in the informed consent of patients in their 50s, for example, who are having clear lens exchange with a clear lens, yeah? The myth about dry eye not being, being a preventative factor for doing corneal surgery in older people is a myth. We were explaining this last night. Glenn and myself in London Vision Clinic, we've done 12,000 patients. Imagine our workload if we were still managing 12,000 patients with dry eye. We would have nothing else to do, or we would be in prison, right? There's no other way around it. The dry eye is not dry eye, it's meibomian gland dysfunction. And meibomian gland dysfunction is exacerbated by any cut in the cornea. Smile, LASIK, lens surgery, ICL, cataract surgery, they all aggravate the neural reflex pathways that affect meibomian gland function. So management of meibomian gland dysfunction is part of all presbyopic surgery. It doesn't matter what kind, lens or cornea. Finally, the overall safety of corneal surgery is the same if you do it on a young eye or an older eye. But the overall safety of lens surgery is better the older the eye. So it's not the same to do a lens surgery in a younger patient. And the last thing is that if you have a lens put in now, you're having today's technology put in your eye. Well, how do we know that in 10 years' time, when you were going to get a cataract, there wasn't going to be an accommodative IOL, which reads your mind. And when you look close, it focuses. I mean, how do we know this? We don't know this, right? The ACO lens from that Jorge Alio has been developing, it accommodates 3 diopters and it's stable at 5 years. So we don't know what the future holds, and locking someone into today's technology, not necessarily the best thing for the patient. So where do we all agree? Okay, let's go to the Socratean argument technique. I think all of us agree that taking out a clear lens under the age of 47, it's not a great idea. I think we all can agree on that. So that's corneal surgery, okay? LASIK monovision, whatever you want to do. Presbyond, of course, is better. But what happens when people start doing Presbyond? We've seen this now. There's 400 clinics around the world doing Presbyond. There's been over 500,000 patients treated. It's a big thing now. What we see is that people start saying, well, you know what? Actually, it's pretty good. Maybe the 50-year-old, I'm going to do that. I'm going to do that. And they go, you know what? This 52-year-old doesn't have cataract. I'm going to do that. You know what? This 55-year-old doesn't have cataract. I'm going to do Presbyond. And what happens is that this limit keeps on getting pushed up. And in our clinic, it got really pushed up. We measure the OSI on every patient that we're going to do Presbyond on. And if the OSI is higher than 1, or certainly 1.5, we tell the patient, this isn't the right procedure for you. You have a lens change. So it's a very easy way to decide which way to go, left or right. But really, we only do lens surgery if there is a lens opacity. So what happens if you get a cataract afterwards? Well, it's great. Well, not great, but it's a great situation because that cataract now, you already have the right amount of spherical aberration in the cornea on the visual axis because that's where you put it with the eye tracker. So all you have to do is select a monofocal lens with low PCO rate, maybe 2-3% PCO rate, great optics, and you can choose a spherical aberration neutral lens, a sphena. You can choose a spherical aberration positive or a negative, depending on whether you want to push the spherical aberration up or down to optimize the spherical aberration from what it is on the cornea. But it's monofocal surgery. And so the side effects are gone, and you're restored to blended vision with a monofocal and corneal EDOF. What happens if you want to have everything, like I did for the great jazz musician Chick Corea, who came with 20/50 cataracts? Well, I said, you're a musician, you work in theaters, you have lights on you, you want to see the audience. With the lights on you, you want to see the audience. You want to see the music, which on a piano is at 60, 70 centimeters. You want to read a book. You want to drive at night. You have a lot of requirements. So your best possibility of spectacle independence at all distances is to do your cataract surgery with a hyperopic target. Once you have the low hyperopia, we will then come back and do the Presbyond on top of your cornea. And once you do the Presbyond on top of the cornea, now you have extended depth of field with monofocal high-quality index lenses with no PCO rate, and that's the best of the best of the best of the best that you can do for a human being. It's premium cataract surgery, comma, no really premium, because it's expensive, because you're doing 2 premium procedures, but it gives you premium vision. And so that's one of the options. So given that 97% of people pass the plus 150 test, given that the suitability is very, very high, and that we are going to manage meibomian gland dysfunction, which we have to do anyway if you're going to do multifocal surgery, and that we're excluding patients with cataract, and that the acceptance test only takes 3 to 5 minutes more chair time than just the standard pre-op, and the fact that the expectations, you don't have to talk to the patient about what their profession is, or what distance they prefer, or do they drive at night, or are they obsessional? Are you an obsessional person? Are you like, do you change your glasses every 3 weeks at the opticians? You don't have to ask them any of that, because the treatment is the same if you're 49 years old or if you're 74 years old without cataract. It's the same treatment. It's plano, minus 150, with EDOF in each eye. It doesn't matter how old you are. Finally, I will just remind you that we teach a hyper-condensed fellowship of 4 days every year in May in London. In November, we teach a 2-day hyper-condensed therapeutic refractive surgery on complication repairs. And the next course is at Aadithreya Hospital at Sriganesh's home in Bangalore, where we're combining the London Vision Clinic course with the Aadithreya practical course for surgical experience on people. And so, and of course, the costs are much lower for us when we're doing this course. It's normally, £2,500 in London, which is very expensive to fly to and very expensive to stay in a hotel. In Bangalore, we of course we can do this at a much lower reduced fee, and we charge trainees practically nothing. So trainees, we encourage them, send all your residents, because this is their opportunity. And optometrists, who are critical components of refractive surgery, we like to encourage them to come also. So I thank you very much for your attention. I look forward to the discussion for the rest of the session. Thank you.
Thank you so much, Professor. I think Presbyond's always been a very mysterious subject for everyone, and everyone here is probably wanting to start off with Presbyond, and you did an amazing job demystifying the subject with the concepts. I just have one quick question and then we'll move on. You have very detailed SOPs or standard protocols for optometry and surgery, and I just wanted to ask, is how important it is to strictly follow those guidelines and how it affects the outcome?
It's the same as any surgery. If you do sloppy IOL master captures, you'll get sloppy results. If you do sloppy refractions, you'll get sloppy results. So when you say we have strict SOPs, excuse me, all surgeons should have strict ISOPs on all procedures. Trabeculectomy, chalazion removal, blepharoplasty, all surgery should be standardized. And Presbyond is standardized. But I want to say, it's not difficult. I mean, it's refraction, plus 150 test, explain the adaptation curve, and then do LASIK. I mean, it can't be simpler than that. There is no more extra. In fact, there's less airtime with Presbyond than with clear lens exchange with diffractive optics. Because, if you know, the post-op hand-holding and antidepressant prescribing and psychiatric referrals when people don't adapt to diffractive optics can be quite severe on you. Forget about the patient, right? So it's less chair time, it's not complicated, but yes, of course it's standardized. And like anything, if someone says to me, we are using your exact refraction protocol that's in the book, then I know they're going to get great results. And when someone says, oh, it's not working, then then you're not doing it the way, you're not copying what works. So everything is to do with copying. I come to these meetings and I hear something and I immediately copy it and I change my SOPs because I'm just trying to make things better. It's not my way, it's what is the best way. Yeah. So standard operating procedures, I mean, your clinic is phenomenal at that. I mean, it's like a clockwork. When I was very busy. So, and I'm sure all of you are the same. Once you're experienced, you have a system for doing things, and Presbyond is not any different.
Thank you so much. We'll have the next speaker now talking about the visual outcomes after Presbyond laser blended vision. Chao-Kai Chang.
Okay, very thanks my mentor, Reinstein, and I'm Dr. Chang from Taiwan, Nobel Eye Group, and I'm very delighted to have the opportunity to present our research of Presbyond. And our study can prove the theory and the statement from the Reinstein. And just to brief introduction to our company, and we currently have 28 clinics in Taiwan, and we will have 30 by the end of this year. Actually, since 2022, a total of male 90 were installed until now. So we can say that we have some experiences with male 90 and Presbyond. Actually, through the years, with the assistance of the Zeiss group, our reflex surgeon and our optometrist have underwent several training sessions to establish the standard of procedure of Presbyond, as well as the smile and smile procedure as well. And we have also modified our own close blur test documentation to improve our result after taking the LBB course in Hong Kong and other countries. So talking about our study. So this is a prospective case series, and the parameters include, distance, intermediate, near vision in both monocular and binocular settings. And we collect data on DC-IBA and DC-NBA, as well as the change in stereopsis and the contrast sensitivity. And most importantly, we include patient satisfaction questionnaire, just like Reinstein had mentioned, at about 6 months in order to evaluate both subjective experiences and objective data and the spectacle independence. So talk about our pre-operation demographic data. Here are the pre-operative characteristics of our patient. So we only have 42 myopic eye were included in this study since last November. And the average age of the patient was 48 years old. The mean spherical equivalence was approximately minus 5D. Astigmatism ranged from 0 to 3D diopter. For the intended target refraction, the distant eye was targeted at plano 0, and the near eye was targeted between -1 to -1.5 diopter, depending on the patient's tolerance. Okay, so we correlated with, as you know, standard night graph after the reflex surgery with our own standard operation procedure. So we have 10 results. First of all, we're talking about the achieved mean spherical equivalent. The achieved mean for the distant eye was very close to the plano. For the near vision, the mean was -1.6 diopters, and which was very close to our intended target, 1.38. And the second part is talking about the spherical equivalent accuracy. As for the refractive accuracy, 91% eye achieved spherical equivalence within half a diopter. The third part, we're talking about the residual astigmatism. So we can see from here, over 95% had a residual astigmatism less than half diopter. Talking about 3 months for all eye correlation. And the correlation between the attained and achieved spherical equivalence was excellent, with R square of 0.96. And this showed the Presbyond over high predictability and the precision in achieving the desired refraction. So in terms of the pre-CDBA and the post-UDBA, that is about the visual acuity. By 3 months post-op, 100% patient achieved CDBA of 1.0 or better, and 95% patient achieved binocular UDBA of 0.8 or better. And talking about the difference between UDBA and pre-op CDBA, 86% of patients achieved an UDBA that was non-inferior to their pre-operative CDBA, and then no eye experienced a loss of more than 1 line. That's this LASIK is accurate, just like Reinstein have mentioned. Okay, in terms of a CDBA change, and that means the safety, and the safety remain the top concern in all the refractive surgery. So our data show that no eye lost more than 1 line of corrected distant visual acuity, and 100% was within 1 line of their pre-op best correct visual acuity. And this strongly support the safety profile of Presbyond LBB in myopic presbyopic patient. In terms of intermediate vision change, we saw significant improvement. DCIBA improved from 0.74 to 0.94 in Snellen, and the increase was statistically significant. And near vision change DCV, NBA, and DOF. As for near vision, the improvement was equally impressive. So you can see the DC-NBA improved significantly from 0.38 to 0.51 at 3 months. And this outcome indicate a significant extension in the depth of focus. So talking about the stereopsis and the contrast sensitivity. So the post-op uncorrected mean stereopsis was 56 arcseconds and maintained very good functional stereopsis. So there was no significant difference in pre and post-op corrected stereopsis. And the last one, we're talking about the contrast sensitivity change. There are no significant change noted in pre and post-op, and the contrast both for corrected and non-corrected. So let's make a conclusion. The Presbyond LBB achieved very good binocular distance, intermediate, and near vision. Also, they maintain functional stereo acuity and contrast sensitivity. And most importantly, DCIVA. DCIVA and DCNVA significantly improve for Presbyond laser correction and suggests that Presbyond improved the DOF. That's what we want, depth of focus. And last but not least, Presbyond is currently safe and effective strategy for presbyopic correction. And we want to thank Thais for having us to be here. And this is our surgeon from Nobel Eye Clinic, and I and Dr. Alexander Chen and Joseph Low. Yeah, they do a lot of effort and contribution for this study. And this study will last for another 2 years. Thank you very much.
Thank you very much. We'll move on to the next speaker. I'd like to invite Dr. Anton Van Heerden to talk about comparison between the 500 Hertz and 250 Hertz this round. Thank you for keeping to time.
Good afternoon, and thanks once again for having me, inviting me to talk. Talking after Professor Reinstein is a bit like being a choir boy after Pavarotti's been performing, so forgive me if it's a little bit underwhelming. All right. So, Presbyond laser vision correction, comparing 250 Hertz with 500 Hertz. Let's crack on. So, I'm not going to go into this too much, but we know that Presbyond's been around for over 20 years, or it's evolved over 30 years. My journey with Presbyond started in 2019 after attending the full front refractive surgery course. I opened my clinic in Melbourne soon after that. We had the Zeiss refractive suite with the VisiMax 500, and really I started doing Presbyond from the outset using the CRS master, the VisiMax 500 and 250 Hertz on the MEL 90. In December 22 we upgraded to the VisiMax 800, and in April 24 we changed from using the CRS master to using refractive workplace and upgraded to the 500 Hertz on the MEL 90. So this quick study is just a look to assess if that change to 500 Hertz has made any difference to our clinical outcomes. It's a retrospective analysis comparing 138 eyes in the 250 Hertz group with 93 eyes in the 500 Hertz group. We looked at, compared the hyperopic group, the myopic group, dominant and non-dominant eyes, and looked at their data at 6 months. So a quick look at the results. In the myopic group, in the dominant eyes, there was a clinically significant improvement in the distance uncorrected visual acuity. And the hyperopic groups there was also an improvement, but it wasn't clinically significant. So overall, you can see our results there. So we're getting 93%, 6.6 binocular unaided. And if you break it up into myopia and hyperopia, the hyperopes are 97% 6.6 or better, the myopes are 87% 6.6 or better, uncorrected. In the non-dominant eyes, the results are very similar, and our binocular uncorrected near vision, we had 96% patients who were N6 or better, and 74% who were N5 or better, which was an improvement from the 250 Hertz. Enhancements, there were 7 enhancements of 5% in the 250 Hz group and 3% in the 500 Hz group. The safety signals were slightly better in the 500 Hz group, and there was no difference in the non-dominant eye safety signals. So just to summarize the results, we've had improved binocular distance vision, we've had improved vision in the myopes, in the hyperopes, we've had improved residual spherical equivalent, and our near vision statistics are good. I've put there poor statistic, and the reason for that is because we don't treat everyone, we don't give everybody minus 1.5 diopters. It all depends on their tolerance, so we sometimes titrate it back, and we've had a low enhancer rate. That's all very good and well, but what does this really mean for our patients? So this is a typical patient who comes to see us. She's a 52-year-old school teacher. Her uncorrected vision is 6/6, so she doesn't need glasses to drive. That's her refraction. She's suitable to have LASIK. She's got normal eye, no cataract, and tolerates the monocular blur test. So my surgical solutions that I can offer for her are, number one, Presbyond, or I could do a refractive lens exchange using a bilateral EDOF, a bilateral trifocal, or enhanced monovision lens. Those are the surgical options that I can offer her. Let's look at this. So if I give the patient Presbyond, well, I can say that there's a 3%, sorry, my math is terrible, there's a 3% chance, according to my study, that an uncorrected distance vision is going to be worse than it is now if I do Presbyond. If I give a bilateral EDOF, or like Vividi IOL, according to this study, there'll be a 21% chance that an uncorrected distance vision will be worse. What about a trifocal lens? So this is looking at panoptics. These are actually really good results for patients with cataract, but this patient doesn't have cataract, and in this study, my patient would have a 40% chance that a distance uncorrected visual acuity will be worse. Last but not least is the Ray 1 EMV, enhanced monovision. Also really good results for patients in cataract, but my patient's going to have a 26% chance that a distance uncorrected vision will be worse. So it's a no-brainer as to which option will give her the best visual outcome. And also, with Presbyond, there's a 0% chance that any of these nasties are going to occur. If you look at a myope, so this is a typical patient, 50-year-old plumber, same statistics, a little bit less. You've got a 10% chance that it won't get 6/6, but that usually gets better with time. However, as Dan said, it's probably got a 10% chance, 1 in 10 chance that he's going to get a retinal detachment if we use any of the other options. So just to conclude, Presbyond, as we know, is a great option for these patients who have presbyopia in the absence of cataract. It's safer, more predictable, gives better outcomes than all the surgical alternatives. The 500 hertz has improved my outcomes compared to 250 hertz. Thank you very much.
Thanks very much for saying that. I'm going to ask Dan a question about this. So you probably know the answer. I mean, apart from speed, what else has changed from moving those of you who are moving from 80 to 90? Yeah.
Well, the workflow. In other words, now, when you're doing Presbyond at 500, it's because you've got an upgraded MEL 90 motherboard. You have now the refractive surgery workflow, which means you have the visualize integrated, you have the programming of the case that gets sent over your network to the lasers. There's a lot, I mean, the workflow is much better because you don't have to enter the data all over the place. As Anton showed, we know that 500 hertz does the treatment faster, and we know that LASIK is a time-based procedure. So variability in time leads to more scattering results. So that's why speed matters in excimer laser surgery. Let me just point out, because I know that some people in here think that they're operating at 1050 hertz. You think you're doing that, but you're not. You're actually operating at 500 hertz. 1050 hertz is the maximum speed, and that laser goes up to 1000, then back down for a few seconds to allow the surface to cool, then back up, then back down. You know that, you can hear it, right? And that's the average speed is 500 hertz. Why are we using 500 hertz? Because the thermography studies that were done on the cornea showed that we don't want to go faster than 500 if we want to keep a constant ablation rate, because you heat up the tissue too much. So whereas marketing, again, has been used in a negative way to mislead people into thinking that they've got something better, in fact, it's probably better to not vary the frequency during the treatment. Not heat the tissue up, let it cool, heat the tissue up, let it cool, but just do the treatment and get out. So I don't know why I put that in there, but I just felt like it.
I just had a question. With the 500 and the refractive workplace, do you get the data for centration and cyclotorsion from the IR Master 700?
We-
Because that's a problem with the Presbyond, because you can't do a cyclotortion.
Correct, yeah.
Not yet, but you're right. That is, you remember the MEL 80 with the WASCA had cyclotorsion control, and that hasn't gone into the workplace yet. However, let's not forget that the MEL does have manual cyclotorsion control, right? You put the horizontal marks, and use a button that draws a horizontal line, horizontal to the axis of the ablation that you're going to do, and you just move the patient until the axis is correct. So it's not active cyclotortion, but it works.
You have to move the head, which is quite uncomfortable.
Yeah. Well, I move the whole body. I just have them go, yeah.
Thank you so much for that talk. It puts things into perspective. So we'd like to call upon the next speaker, Jiwon Jeong, early clinical outcomes of Presbyond as a beginner.
Yeah, thank you. I'm Dr. Jiwon Jeong from South Korea. Welcome, South Korea, a lovely city in the Seoul. According to the Dr. Reinstein's presentations, I must have been to all 3 planets. Oh my God. I already experienced multifocality and the speculation used the depth of field and monovisions. Yeah, let's start. Today's my topic is early clinical outcomes of Presbyond as a beginners. This is my financial disclosures. Before talking about my Presbyond experience, I will share my presbyopic surgery journey. In 2013, I started with conventional monovisions. Monovision maps was up to 1.5 diopter. The results were relatively good. However, intermediate vision and the stereosis was poor, and sometimes the patients complained about the photic phenomena. These are weak points of the conventional LVC monovision surgery. From 2016, I did presbymax surgery, multifocality. The main ablation profile was multifocal zone ablations. There are several subtypes like monovisions, micromonovisions, and the hybrid according to central adding powers. The results were also good. However, sometimes compliance of their far vision, even if it does it correctly with glasses. So I used to only presbymax treatment, only one eye. And this is my last case of a presbymax case. After this case, I didn't do presbymax surgery. Both side topography shows well-demarcated multi-zone, fantastic. However, patients complained that their visual acuity far and near. And then I consulted this photography and the visual acuity to Schwint and their expert surgeon. The reply was the result was perfect. And just wait, the patient's visual acuity will get better. However, after 3 months, the patient's visual acuity is not so good. I decided to the reverse procedure on dominant eye. The reverse procedure means the multifocality to conventional ablation. So eliminate the multifocality. After that, dominant eye recovered to its far visual acuity. And this is 3-year post-topography. Right eye have a very good far visual acuity, and the left eye have multi-zone with a relatively smooth transition zone. It's the key, smooth transition zone, compared to 2 years ago. There are little improving in near visual acuity, and however, they still complain with their near visual acuity. That's problem. 2 years ago, I have chance to do presbyopic PT IOL surgery, RT plus IOL. Prior to launching, I have high expectations and thought that RT plus can do everything for presbyopic patients. It is based on the precision multifocal IOL, use same geometry, and it uses 2 plus 2.5 diopter adding. Its results were pretty good, however, decreased intermediate visual acuity and long adaptation time are still problems. Most of all, it is hard to target or get the predicted plane of target. So not so good results in the mild to moderate myopia. I think this is the most weak point of peak IOL surgeries. Around the same time as Arctipus, I had a chance to do Viva ICL. The difference from Arctipus, it has only 1.5 diopter adding effect with spec calibration inductions. Kind of edophile. Also, it is hard to target planar and the no toric version. It's mainly limitations of the Viva ICL. Sometimes patients complain unsatisfactory near visions. Arctipus is weak at intermediate visions and Viva is weak at near vision. This is different point. On the other hand, hard to get planar target is common point of two taking IOL surgery. It's very important. In the late 2025, final man to Presbyond LVV surgery. As you know, it uses preoperative a tolerable monovision amount and induce controlled spec calibrations and needs some brain adaptations. It's very short times. Its results are very good so far. A good all distant, intermediate, and near vision, and a good stereopsis, less phenomenon. These are strong points of Presbyond LVV surgery. In case of intended spec calibration inductions in all eye surgery, the centration is very important because of this center always makes common aberrations, and it is always correlated with severe visual degradation in the presence of spec calibrations. So to make good centrations, the many skills were introduced. CSCLR, the coaxially cited corneal light reflex, is most correlated with visual axis so far. So in Presbyond surgery, using CSCLR is a very important point in addition to using controlled specular aberrations. This 39-year female patient wants to take off her glasses. She is about minus 2.5 diopter myopia and a very good near visual acuity with glasses. In this case, which surgery do you choose? LVC surgery or LVC monovision? Most experienced surgeons do not choose only LVC surgery. Usually, over late 30, myopic patients complain their near visual acuity after LVC surgeries. This paper shows why patients complain decreased near visual acuity after conventional LVC procedures. This paper compared the pre- and post-LASIK accommodation functions. Accommodative amplitude decreased about 2 diopter after LASIK procedure, and accommodative facility increased after LASIK. So many of the LASIK patients complain their near visual acuity after surgery. Actually, this is my first case of the Presbyond LVV surgery, a 39-year-old. Presbyond target is minus 1 point diopter for non-dominant eye and planar for dominant eye, a slight decrease of monovision amount. Post-visual acuity was 2016 in dominant and 2020 in non-dominant eyes, even if she has minus 1 diopter offset. Binocular near visual acuity was J1 plus. Postoperative defocus shows very widened depth of field, about 1 diopter compared to preoperative state. The reason why I choose this case as my first case of Presbyond surgery is I worried about the results, the patient's results. You know, always first case is very thrilled and depressed. Yeah. For example, Presbyond monovision with the 50s, after surgery, the patients can't adapt postoperative status. As I mentioned, I already experienced the monovision, LVC monovision and the Presbyond surgery. In very similar case, in those cases, I have many times experience about the patients complain. So I was thrilled. So I make a very early presbyopic patients with small amounts of monovisions. Oh, of course, the patient was very satisfied with this. So I'm more convinced after this case. But this is another case, the most popular case currently. 52-year female office worker had a lot of computer work. Her refractive states are moderate to myopia in both eyes. The near visual acuity was J6. Intended target were minus 1.25 diopter monovisions. Post-op 3 months, her right eye was 2016 and the left eye was 2030. and the binocular near visual acuity was J1. The patient was very satisfied and no visual disturbance in usual life. This is post 3 months defocus curve. You can see the very wide and the depth of field. Last case, hyperopic Presbyond case. In Korea, hyperopic patients are relatively small compared to the myopia. Usually, the doctors do myopic Presbyond and do hyperopic Presbyond sometimes. 53-year female accountant wants to take off her glasses. Her refractive status was +3 diopter hyperopia in both eyes. Near visual acuity was J1 with the adding glasses. She got a Presbyond surgery. Intended monovision amount was -1.5 diopter. At post of 3 months, her right eye was 2016 and the left eye was 2030. Binocular visual acuity was the Jiwon with planar. She was very excited with the results at every visit. Yeah, this is the 3 months post of the depth of field. I think it will be helpful to understand about the correlation between spectral aberration and the depth of field at this. This paper shows positive spectral aberration extend depth of focus to hyperopic defocus, and the negative spectral aberration shifted it toward myopic defocus. Usually, negative spectral aberration have more focus to near and have relatively narrow depth of field, and on the other hand, positive spectral aberration have more defocus to far or relatively wide depth of field. And the myopic patients complain always about near vision, and the hyperopic patients complain the far vision after LVC surgery. In myopic Presbyond, non-dominant eyes defocus curve stretch to hyperopic way, like left pictures, toward the planar. It makes better intermediate visions. However, in hyperopic Presbyond, non-dominant eyes defocus curve stretch to myopic way toward more myopia. It makes better near vision. However, worsen sometimes intermediate vision. So, in my opinion, I make a monovision amount more aggressively in myopic cases and more conservatively in the hyperopic patients to preserve intermediate vision and to preserve stereopsis. Yeah. Conclusion, there are so many options to correct the presbyopic conditions like a presbyopic LVCs and the LVC monovision, the PK IOLs, RLE, etc. To make a decision, which option you choose is very similar with the young myopic corrections. Firstly, you can choose presbyopic LVC surgery like a Presbyond LVB. Secondly, in case of high myopia or thin cornea, etc., you can choose PK IOL. And lastly, you can choose RLE surgery. In my opinion, so far, Presbyond LVB surgery meets patients' expectations mostly. Yeah, last, never be afraid or hesitant to do Presbyond LVB surgery. Thank you. Do you have any question?
What about you? Are you hesitant?
Yeah, we discussed
or
last
afraid?
night. Yeah. Always real.
I think you highlighted a very key point, which is basically patient selection.
Mm-hmm.
So I think the patient selection, and that comes with experience as well. I mean, how you choose your patient.
No, I disagree.
Mm-hmm.
That's multifocal surgery. Patient selection is like falling off a log with Presbyond. You don't have to ask their profession. You don't have to ask if they drive at night. You don't have to ask what distance they prefer. You don't have to ask anything. You just have to, explain their recovery curve, and 97% of emmetropes pass the +150 test. So there's it's not patient selection. It's actually just counseling. Multifocal surgery, patient selection, critical, very important. The Dell questionnaire, very useful. It screens out crazy people who are not going to adapt to a compromise in the quality of vision. But Presbyond is not a question of patient selection.
I think what I meant was choosing the patients that will reach that satisfaction. Whether you're appropriate or not is not the question. It's whether they get satisfied with Presbyond. In Asia, then, most of my patients are either myopic or highly myopic. We do see patients, I can show you our charts. I mean, we do have a lot of patients who are surprisingly, lose their accommodation surprisingly early.
Right.
Yeah. And so I think for us in Asia, what I mean by patient selection is will we be able to achieve those results in that patient? And then we explain it to the patient, of course. And then the choice, is a discussion with the patient. So I think we'll have cases.
But if we look at Dr. Van Heerden's talk, I mean, the alternative that is currently most common is clear lens exchange. Now, you have to set the expectations bloody low to get patient satisfaction, because the 20/20 rates are between 60 and 80%.
Yeah.
So in other words, Presbyond is a lot less trouble for patient selection. Again, do you see what I mean? So if you, I agree, and there is a study, Dr. Feng Zhu from Beijing, she published a paper actually showing that accommodation deficit occurs earlier in Asian eyes, and that's true. In London, I see 38-year-old -3s who can't read through their distance correction, and they get Presbyond. Something that you showed, which I thought was really important to understand, is that with a -0.75 refraction, the eye is 20/20 at distance. So we're only compromising a little bit more the distance vision to get full near in someone with less accommodation. Yeah, I think I think your last slide is correct. You must not think of Presbyond as some dangerous, crazy thing. It's a modification of binocular vision. It's the least crazy thing that we could do to a presbyopic patient, actually.
Yeah, the reason why the -0.75 diopter can see the 20/20 is the specular-induced depth of field was widened, and the planar target, the planar or depth of defocus curve are widened. So yeah, that's why the lesion.
Thank you. This talk also goes to show that you try all the options available on the table for presbyopia, and you settle at Presbyond. So this is the safest and one of the most effective ways to treat presbyopia today.
Yes, as I mentioned, I always use the Presbyond LVB. It is available. It's not so good conditions, corneas or etc. As the second, choose the taking of a surgery. And lastly, or sometimes very old age, I choose the RLE.
Thank you.
Thank you. Next speaker, please. Dr. Varman is going to talk about key insights to a successful start for Presbyond. Thank you very much.
Yeah, that's right.
Hi. So, good evening, everybody. So, my talk today is the key insights for a successful start of Presbyond. So, I'm going to speak to you in the perspective of a clinic that's been doing Presbyond for the last year and a half now, and what you can do to get a head start when you're starting this procedure. So, these are my disclosures. So, many of us have a confusion about what Presbyond is exactly. So, you might have heard about it in passing. The unfortunate thing is, usually it is clumped together with all the other presbyopic laser vision correction procedures. We think it's all the same, and we all think it doesn't work as well. So that's something that we have to change within ourselves and make an effort to understand the procedure and see how it actually works. So you've heard Professor Dan's talk in the beginning, and now we all know it's not just monovision. It uses a concept of monovision, but it does extend the depth of field by targeting it in both eyes, where the distance eye also gets reasonably good intermediate and near, and the near eye will also get reasonably good distance vision. So this is not just simple monovision. So my curiosity about Presbyond started in 23 in the Zeiss user meet, when I first heard Professor Dan's talk about it. My first reaction was, okay, are these results real? And if these results are real, why are not more people doing this procedure? So that's when I was encouraged to attend the forefront refractive surgery course in the same year. And after attending it, I was convinced enough to go back home and get a MEL 90 just for the express purpose of starting Presbyond, because most of our myopes were all treated with SMILE, very few hyperopic LASIK scattered now and there. So the MEL 90 was purchased expressly for the purpose of addressing presbyopic patients with the laser vision correction by doing Presbyond. So my first Presbyond patient is actually quite interesting. It happened to be an ophthalmologist. So she actually came to our clinic for the purpose of getting SMILE for her daughter done. After this was done, she said, can I also have a similar procedure? That's when we got the MEL 90 and I said, I have Presbyond, do you want it? She accepted. So till now, I had heard all the theory about Presbyond in the forefront refractive surgery course, but I was still a little nervous about the outcomes here because I had not done a single procedure yet. But once we did this procedure, did I really realize that this is not just simple monovision. So this was the pre-op refraction for the patient. On the right eye, she was minus 5.5 correcting to 6.5. Left eye minus 7.25 correcting to 6.5. Near vision, she was N18 with a plus 2.25 add for N6. We did the simulation testing and she was dominant in the right eye with a minus 5.5 for 6.5. Her uncorrected near vision in the dominant eye was N18. The left eye, which is the non-dominant eye, with a plus 150, she was able to read N5 for near, and the distance was only 618 though. But post-operatively, you can see the difference here. Her uncorrected distance vision is 6.5, intermediate is 6.5, near is 6.5. But what's happened here is the dominant eye, which is the right eye, went from N18 from near to N10, which is almost plano. Similarly, in the non-dominant eye, which is the left eye, the minus 150, which reads N5 for near, her distance vision is about 6.9 parts. So once I had done this case, I realized, yes, this is not just a monovision. There is, in fact, an increase in the depth of field in both the dominant and the non-dominant eye, which leads to a blend of both eyes, and that's why patients are quite happy. So, but to be honest, the first 6 months, the results were good, were sometimes not great. I had some patients who were off target and did complain of cross blur. Particularly, I had some trouble with the low myopes and the emmetropes. So that's when I had some help from Zeiss, where they had this onboarding program, where they had an optometrist who was experienced in this procedure, Mr. Sandeep, who came to us and gave us a 2-day intensive course. So all of our standard operating procedure was reviewed, and he made small suggestions so that I could fine-tune my SOPs and get better results. The most important in these changes was standardizing the preoperative testing, including the refraction, the dominance testing, getting the functional age right, and also the Presbyond acceptance test. So my learning curve from this onboarding course was that the refraction has to be extremely precise. So with Presbyond, you really cannot afford to be more than 0.25 diopters off target. Reason being, let's say you target minus 150 in the non-dominant eye, and you land up with minus 2. With the minus 2, you're not going to have a blend. Similarly, in the dominant eye, let's say you have a minus 0.5 residual. When you have a minus 0.5 residual in the dominant eye, because the dominant eye does most of the work for distance, it's going to have cross blur. So for these reasons, you really have to be on target for all your eyes. And it also works best if you can measure the preoperative spherical aberration. So this is because Presbyond algorithm, it puts a spherical aberration within a target zone. So unless you're in this target zone, you're not going to get that depth of field without diminishing the quality of vision. So once you have an aberrometer that can measure the spherical aberration pre-op and you enter it into the treatment planning, your results are going to be much better. So our results were quite good. So we've done a little over 100 patients now. These are 86 patients with about 3 months follow-up. All of the patients at least achieved 6.6 for distance and N6 for near. 78% of patients achieved 6.5 with N5, and 5 patients achieved 6.6 with N5. And this next slide for me is a real eye-opener because this is an eye trace image where we see the pre-op image of the depth of field. The eye trace actually allows you to give you an objective measure of the depth of field in monocularly and binocularly as well. So as you can see here, in each side is about 1.3 and 1.69, and for both eyes it's about 2.2. This is pre-op. Post-op, the depth is increased tremendously. So post-op, you can see it increases about half a diopter in both eyes, and binocularly it increases by almost 2 diopters. So this is something we're currently working on and doing an analysis on to see the change in the depth of field both in the pre and post-op in the eye trace. So I faced a unique challenge when I came back home. So this is when I spoke to my father, who I work with, who has 40 years of experience now in surgical ophthalmology. So he was a big fan of doing clear lens exchange for multifocals and trifocals. So October 23, I came back and I said, let's start doing Presbyond instead of clear lens exchange. And his reply was, I'm not going to stop doing clear lens exchange, find your own patients for Presbyond. So this was challenging for me because we both be fighting for the same patient cohort. But then in Jan 24, he said, straight off the bat, all the complaints that my clear lens exchange patients have is not there with Presbyond. I will prefer Presbyond as a first option for the correction of presbyopia in the absence of cataract. So patients do not have night vision issues. They don't come back and complain of contrast loss. They don't say I can't see at night without bright lighting. So that is a major thing. In October 24, he said Presbyond is the most gratifying procedure to perform in the last 40 years of practice. And finally, in Feb 25, he got Presbyond done himself. So this is my dad's profile. So he is 67 years old. He had no nuclear sclerosis at all. So we have a clear distinction, like how Professor Dan mentioned. In the eye trace, when you look at the dysfunctional lens index, if the lens index is less than 6, that means the patient is going for a nuclear sclerosis. Dad had a lens index of about 8 to 9, so which meant his lenses were absolutely clear. He had against the rule astigmatism pre-op, and post-op now his binocular vision is 6.5 and 5. He's got no problems whatsoever. The fun fact is, I did the Presbyond for him on a Monday evening at 5 p.m. Tuesday morning at 9 a.m. he had 7 cataract surgeries lined up. So I was a little optimistic, but I was also a little scared as well, because I did not know whether I've taken away my dad's ability to operate and whether I've affected his depth perception negatively. So next morning I was all scrubbed up in the operating theatre and I was ready to take over the case in case Dad couldn't operate. And I was just standing the whole time. There was no issues whatsoever. He was able to operate happily. 7 cases back to back, no issues whatsoever. And this is a testimonial, which is a very short clip. I'll just play it for you now. Audio. Yeah. No, there's no audio coming.
Class 7, my distant vision correction was very tiny, so I needed to wear it just to see a little more clearly. But the need for glasses became permanent only after the mid-40s, when reading became impossible without glasses. So yes, at 45 when I started wearing glasses, there was no option. And I have seen the results at our patients, over 100 of them, which are brilliant. Actually, I am a fairly sensitive person as far as the eye goes. Surprisingly, I didn't feel any difficulty at all. Absolutely, I was fine. The procedure is absolutely painless. It just takes about 10 minutes. Post that, yes, that 6 hours of irritation watering in the eye is there. I got it done on a Monday evening at 5:30, and next morning at 9 o'clock, Tuesday morning, I was into the theatre doing microsurgery.
So now you're totally functional. You're able to drive at night, you're able to watch TV, you can read a book at near, you're able to have good intermediate vision at the range of your computer. Do you ever miss your glasses?
Absolutely not. Even though I had clear vision in my glasses, I would get migraine quite frequently when I start working, reading for some time. That having gone away, it's like a switch gone off, my migraine disappeared overnight. Particularly the greys and blacks are very crisp. That's important because for any image to be seen clearly, it's the blacks and the shadows that give you the depth. Suddenly I find that I have even normal vision, driving, everything. There seems to be far better depth than I ever had in my life. So that was a very interesting point that Dad made, so I don't understand that completely myself. My hypothesis is, in the pre-op procedure, he actually had a little higher amount of spherical aberration than I usually see in most of my patients. So I guess that Presbyond has got that back into a target zone, and that's why his contrast is improved. So that's a good bonus for him after getting the procedure done. So this is another comparison where we compare the number of clear lens exchange versus Presbyond that we have done in our practice for the last 2 years now. As you can see, once you start offering a laser vision correction procedure instead of offering an invasive intraocular lens exchange procedure, the number of takers that you have for laser vision correction is much higher. So you end up treating a much larger cohort of presbyopic patients when you do offer them a laser vision correction instead of a lens exchange. So finally, I conclude by saying Presbyond is an excellent option for the correction of presbyopia in the absence of cataract for myopes, hyperopes, and emmetropes as well. It does require an intricate understanding on how the procedure works. I would highly recommend that you do attend Professor Dan's course in London to understand this. And also, you can request Zeiss to give you the onboarding program where they have an optometrist to come and help you and to fine-tune the procedure so you get off doing the procedure in the correct way. And you will have an unique advantage over your competitors, as most of them will not be offering a laser vision correction for the correction of presbyopia. So that's the end of it. Thank you for your attention.
That was an excellent talk, and congrats to you on starting Presbyond and doing it so superbly for your dad, and that looks amazing. So for the audience, there are a lot of people here who want to start Presbyond.
Yeah.
And also there are a lot of people who have a MEL 90 who are not using it for Presbyond.
Yeah.
So if there is someone like that has the equipment, let's say that they have a 500 and the MEL 90,
Yeah.
what additional equipment or additional training would you recommend for them to start off Presbyond apart from the course, of course?
Okay, so I would say get help from a mentor who's doing it, because Presbyond is a little more intricate in the way you work up the patient, then your accuracy. Your refraction has to be extremely precise. So if you're off by half a diopter, it's not going to work as well. The other equipment that I would suggest that you get before you start would be a dedicated aberrometer. So my first few patients, I had made the mistake of entering spherical aberration as 0. So you might still get on target, but in case the patient has a little less or a little more spherical aberration than usual, you'll be off. So when you have an aberrometer like the iTrace, which can measure the spherical aberration accurately, then you enter it, you're more likely to be back on target. So that would be my suggestion before you start Presbyond.
That's great. I have a question for Professor Dan. How important is it to have a manual phoropter? Because most people now have a digital phoropter, and that was one of the points I remember from your course. So is it compulsory to get a manual phoropter for the, just a question for people who want to start?
No, but it's preferable because the manual phoropter has.
Thank you for having me. I'm Dini from Surabaya, Indonesia. I would like to share my experience with monocular treatment of Presbyond. This is my short CV. I'm cataract, cornea, and refractive surgeon. I'm working with Presbyond in National Eye Center, NEC. NEC is the first clinic doing Presbyond in Indonesia, and currently the only one active doing Presbyond in Indonesia now. This is my LVC procedure in NEC. We can see that the case number of Presbyond grow fast in this year, almost reached the total number last year. And this is my Presbyond journey compared with the all patient in NEC Presbyond, and we can see that we grow together in Presbyond. And this is my case 1, a man 44 years old, came post LASIK 6 years ago and 6 in both eyes, and now he doesn't want to wear reading glasses, and this is my demanding challenge because it's my second Presbyond patient. And I give him special consent that I told him that the method is by relieve the flap. Then I explained that the risk related the flap include epithelial ingrow and flap misalignment. And as we know that the Presbyond is a laser blended vision, that it should be or it must be both eyes straight, but because I don't have many experience to relieve the old flap, I consider to monocular treatment in this patient. And I also explain this patient, if we fail or are unsuccessful to relieve the flap, we have to switch to PRK, and the stability may take time and risk of corneal haze. And also I explained about the outcome, possibility of over or under correction, and the difficulty of me is as beginner give education that the non-dominant eye targeting for reading, it's mean blur for distance, but I try to explain to patient that you must, the both eyes must work together. And also I manage the expectation. I talk to the patient that adaptation may require time, and if we can unsuccessful to adaptation, you still need reading glasses. After all information, the patient still need go to the enhancement. This is the pre-op, the manifest refraction plano in both eyes with at lens plus 1.75 and the binocular distance vision 1.0 near Jiwon, and the left eye is a non-dominant eye. And we only have a device only for corneal aberration, normal, and tolerance test, good. This is a treatment plan with the left eye, the target minus 1.50. This is the post-op, the binocular distance visions 1.0 and near vision Jiwon. Just before coming in this meeting, I asked him to follow-up examination, but this patient go to Hajj in Mecca, but he said that no complaint in daily activity and mantap in English is OSM, lucky me for this case. Then I have a case too. This is a man, 51 years old. He is an army and kept with 3/8 or personal assistant, and he doesn't want to use reading glasses. And the boomerang for me is after I explanation about the concept of micro anisometropia, this patient only one LASIK for the non-dominant eye, the refractive status emetropia with slight hyperopia. This is the pre-op, the left eye with plus 0.50, the adding lens plus 2. The left eye is a non-dominant eye, normal corneal aberration. This is the treatment plan in the left eye with the intended correction, plus 1.73. This is the post-op. The left eye, visual acuity 0.5, but the binocular distance vision 1.0 and near G1. Unfortunately, the first month examination still next week. Hopefully the patient happy. This is my personal experience. Most patient myopia with the distribution of age between 41 to 45. This is my take-home message. Even in ideal situation like my case that necessitated performing monocular presbyond, we have to do optimized pre-op assessments to good outcome, and patient expectations should be carefully managed to satisfaction outcome also. And in my opinion, Presbyond is a highly forgiving procedure. I've been waiting my new toys Presbyond in Undaan Eye Hospital, and at the end, as a beginner, I'm very welcome if the expert Prof. Dan, Dr. Sriganesh, give us as a beginner how to motivate or how to educate patient, and how about counseling about the micro anisometropia, especially like case that I'm facing today. Thank you.
Next we'll have Tang Seng Fai for the next case presentation. I would just like to remind the speakers that we have 8 minutes per talk and we're running a little bit behind time, so I request you to stick to time. Thank you.
Good afternoon, everyone. Thanks, Sai, for giving me these opportunities to share my journey of Presbyond. Okay, need to do it fast. Okay, so my journey started after I attended Prof. Dan's talk in Hong Kong, end of 2023. I was confident. So until now, I have 30 presbyopia patients, went through Presbyond. So I would like to categorize my patient into different baseline refractive error: immature, myope, and hyperope. This comes with some reason. I will explain later. So my patient's age range 38 to 52. Okay, success rate, I will say 100% success. Okay, after post-op day 1, they can get 6/9 at least or better, and 100% N5. But if we define success rate of discharged patient to optometrist group, because I'm from Optimax, is a refractive center. We have a lot of refractive cases, mild, all those things. After we do the surgery, we follow up the patient. Once the patient happy, everything we've discharged to optometrist group for continuation of care. So about discharge rate, until now, I still have about 12 patients still follow up with me. And usually I will able to discharge patient, means patient is really happy. They pass through the adaptation about 3 to 6 months post-op, then they will follow up with optometrists. And the most important challenge about this so-called delayed discharge, most of the time is dry eye and adaptation. So I remember Prof. Tan talks about 9 months for adaptation. Okay, so the important keys, the pre-op counseling is very important. So the challenge is most of the patients, they only will remember what they want to listen. Whatever we told them about dry eye management, adaptation, all those things, they will forget about it. Then when they come for follow-up, they'll keep complaining about adaptation, still dry, the eye, all those things. And for my pre-op assessment, I follow protocol advice from Prof. Tan, the plus 50 tolerance test, and yeah, I don't tell patient which eye to focus. Okay, so, important keys for ametropia patient. Okay, the adaptation challenge is as a distant visual acuity. Okay, most of the time they will complain after the treatment, they will say, my distant vision was better before treatment. But most of the time they're happy with near vision. So during the pre-op counseling is very crucial. We may demonstrate to them, now you see, before treatment you can see 6.5 or even 6.4. I will bring you down to 6.6, which is already 100%. But after the Presbyond, you have a better range of vision. Okay, so this group of patients is most difficult to handle. Okay, then we move to myopia patient. The adaptation challenge is near vision. So it depends on the baseline myopia before treatment. If they're high myopia, there's no problem. -5, -6, they'll be very happy. But if they're -1, -2, it will be challenge. Especially they would complain, I can see better without glasses last time before treatment. So at the point of time, after the treatment, we should educate them. Near vision is like 33 to 40 cm. Not like last time when they have -3, they can see up close like this. So we need to educate them the proper way of near vision. And usually it's easy to handle, myopia patient. So the third one is hyperopia patient. Also quite easy to handle because before the treatment, they can't see neither distant or near. Okay? And post-op, they're very happy. It's easiest to handle. So the challenge from the point of technique is no, it's not a challenge, just like femto LASIK using MEL 90. Pre-op counseling, yes, it's a challenge. I used to see all the patients, I counsel them before the procedure. So I will have a different script. Okay, now patient coming is hyperopia. I know what to do. Okay, so it can make your chair time lesser, faster. And if the patient comes with myopia, what should I tell? Emmetropia, what should I tell? Okay, apart from that, marketing also is very important. Because we have very successful marketing about Smile, Smile Pro. Now, the media we use to market. So we need to remember our target group of patients, 40 to 50 plus. I'm not sure they're still using Instagram or they're still Facebook, newspaper. I did have patients holding a newspaper because we market in newspaper. The whole newspaper come in to see me to request for Presbyond. So maybe we should choose the proper media to market this Presbyond. And of course, versus other options like clear lens, especially more than 50 plus, like 57, 58, it's a bit difficult to convince them because in our country, the average age of cataract about 60 plus, 65. So they will say, after 5 years, I need to do another cataract surgery. So they will more to lens surgery. And of course, now we have phakic lens, ICL, I perform all those options. So I will discuss with patient which one is the best. So frequently asked and difficult to answer if the patient asks me, why Presbyond require flat? So they ask when Smile Presbyond is ready. And of course, they keep on asking, will I get cataract? And if I get cataract, I need cataract surgery. Those questions is especially for those of near 60. And yeah, and like I mentioned, we market very well about Presbyond, Smile Pro. So they come, we asking for Smile Pro monovision. So we need to explain to them what's monovision versus Presbyond, all those things. Thank you.
Thank you so much. After this, we will have a panel discussion about people here who've had Presbyond and their experiences.
Good afternoon, dear the fellow user. And my name is Bai Ji, and I come from the China. And in our hospital, we finished the 100 Presbyond surgery, and some of them is over the 70 years old. And include the manager and the professor and counter. Today, I introduced the patient female with professional counter. 55 years old, and he suffered from the myopia and also the presbyopia. And you know, his distance and near vision is not good. But in this case, his most painful is the intermediate vision. Because he cannot, very difficult to do the computer work. And they also is very crazy about to drive an SUV car, the female driver SUV car. You know that for SUV, the control panel is maybe in the near, maybe in the middle. Also, the distance, the vision is good. So it's very, he tell me that this is I want to drive the SUV. And last year, November, before the Thanksgiving, his doctor gave his mother a gift about the Presbyond surgery information. Then he come to our hospital. And we finished the examination before operation, and but he registered to the lens surgery, and he hastened to which operation is good, is the smell and the presbyond, because he doctor to do the smell to correct the myopia. But I told her, because you are in the stager, in the stager, and presbyopia stager is the absolute stager in this age. To do the just the minimum motivation is not good, because the smell just to can achieve the minimum motivation, and the presbyond not only minimum motivation but also it off. So finally, he decision that he make he want to do the presbyond, and this is to do the quality of life, and examine the 90 machine. And 1 week you can see that is clinical result is good, but after half a year he more happy because he improved his distance and near the vision. And you can see this contrast sensitivity is very good, and corneal mind is good. This is very important. This you can see is the light is the 6 millimeter, and you can see the C12. This is the 0.5, and the 449, and the left eye 0.575. So good. So it's the contrast sensitivity is right. Okay, and this is very interesting for his conversation. How to?
我在想，退休以后买个这个车，开个安全。但是呢，当时就是有这个感觉，就是功能线太多，我有点看不大很清楚。后来动完手术以后，我今年过完春节我回来，我又去看这个车，然后这些功能键我全看得清楚，不管是近视还是老花，就近看的、近的、对近的都看。另外一个就是让我感觉到动了这个手术有特别强烈的好的感觉，就是我去签合同，因为买车所有的签合同啊，去那个定制的看，现在全部都是在网上，都是用手机一个 APP。我开始我自己没这种感觉，所以教授之前说到，就是说你忘记了你是做过角膜手术的，你忘记了你是一个到了这个年龄，要戴老花镜的这么一个年龄。 那我当时也没有觉得，我反正就拿出手机就开始做嘛，不管是那个近视的，反正你都能看。然后就是我的那个销售经理，我都签的差不多了，以后准备要签字的时候，他说有些东西我都要放大去看，他说你的眼睛还挺好哎。然后我才想着我是没有戴眼镜，没有戴花镜，也没戴近视镜，然后我拿着一个手机就把整个这一套全换下来。
Very interesting. Oh, next typical case is me. Yes. Just to see, this year I'm 66 years old, and I also suffer from the myopia and presbyopia. And last day, and performed the Presbyond, and now I distance and close reading is good. And you can, the people of the Daily of China reported the news that in order to welcome the new year, the doctor received the Presbyond. Okay. So, this is my decent, and this is my the video quality. So I see. Now I forgot that I have the cornea surgery. I also forgot that I'm at the age, this age, I should to wear reading glasses. Okay, thank you so much. Thank you.
Thank you so much for sharing your experience. Our last session for today is a discussion about first-hand experiences as a patient that has undergone Presbyond. I would like to welcome Dr. Bai and Dr. Sriganesh to share their experience as the one-year experience and the 10th year of having undergone Presbyond.
Okay, first. Okay, I can, Chairman, may I ask the Reinstein and to together to play your role, why I to receive the Presbyond, because this is a conversation, your role in the here. Would you please come here? Come here. Come here. Okay.
And of course, the surgeon for both of them was
Yeah, this is very interesting. The real story, very interesting story.
You have the slides? Oh, yeah. Okay.
Huh?
That's fine.
Oh, how?
Maybe we
Give
start.
me the slide.
Yeah, can we have Dr. Shree's slides? Yeah, we have both slides.
Yeah. Okay. Okay. You can see last year, the May, I went to the London and attended a special course from the Dan Reinstein. But before the special course, Dan will give me, we will have the conversation in the WeChat. You can see it, okay? You can see.
Yeah, so we were on WeChat, and I said, oh, I see you've signed up for the course. I'm very happy that you're coming.
Yeah, but this is a very good opportunity to learn something. But he gave me a big question.
Yeah, I said, so, well, it's great, but I have a big question for you. Shouldn't we do your own Presbyond? Wait a minute. No. Shouldn't we do your own Presbyond while you're here? You know, this has a huge impact on your practice, you know, not just the vision benefit for yourself. What do you think? And then he didn't answer me for like, he just disappeared. And then so about 2 weeks later, I said, hello.
Yeah.
And then,
Yeah, but I'm hesitant why to maybe I can do and cannot to do. So this is I tell the Dan that my the vision is okay, just okay. Distance and the near vision is okay. Okay.
I said, really? Look, I was minus 0.75 in both eyes, and I could see 20/30 at distance and N5 at near when I had surgery, and it's the best thing. I have perfect 20/20 at distance and N4 at near and N5 at intermediate, and that's been for the last 8 years and completely stable. What is your actual refraction?
Yeah.
So he sent me this, which is an auto refraction, and I said, well, So then I said, wow, that was my refraction also. You know, I was on a safari in Kenya. I couldn't see the leopard in the tree. I went back to London and I got my Presbyond. I functioned 100% without glasses before my Presbyond, but I didn't see sharp without glasses. And trust me, if you got Presbyond, you would be so incredibly happy because you would see so clearly at distance and you would still have great near vision. Don't be scared. I will make a special perfect surgery for you.
Yeah. So the leopard in tree, this is real, really. I just asked me no, and finally I went to the, London and see the movies and the other South American professor to do this Presbyond, and even the Oscar is the age is 80 years old.
Yeah.
But so I make a decision to do the Presbyond. The last day, and Professor Dan come to our hospital to do the operation just like this. This is why I do the Presbyond.
So
Okay.
Dan forced you to get it.
Yeah, thank you so much.
Yeah, and then about 10 years ago,
Yeah.
I got an email from Dr. Sriganesh, and he said, you know, I would like you to come to my meeting at the end of November in Bangalore. We have 500 surgeons. It's every year. And, oh, Sri, you know, the problem is that end of November, it's close to Christmas here. Travels is difficult. And then he said, yes, but I want you to perform live surgery here. I said, all right, well, maybe, really? What do you want me to do? He says, I want you to perform a live Presbyond at the meeting. I said, well, okay. Yeah, but I want you to perform it on me in front of 500 ophthalmologists. And I said, yeah, okay, now it's starting to get interesting. And then he said, and I will have an Indian classical musicians, and you can play your saxophone with them. And my wife sings. And I said, okay, I'm coming.
After 10 years at Ganesh, how about you?
Yeah.
So we just have about 5 minutes left to the session. Sorry to hurry you guys up. It's a great story. But we have another session planned after this. So let's just quickly finish.
Okay, so Dan gave you the introduction, and then it's been 10 years, 2015, I had my Presbyond surgery. So let me show you my pre-op, my 1 year, and my 10-year Presbyond results. As you can see, I'm not wearing glasses. This was my pre-op data. I was hyperopic, +1 with half a cylinder in both the eyes, and that's my topography, 2015. And that's the Atlas topography. You can see it's perfectly normal. And that's the planning, CRS planning. So the right eye was dominant, left eye aimed for 1.75 diopters of myopia. And that was the surgery being done. And you can see Dan is checking the machine. And this was a live surgery session with about 500 ophthalmologists. Can you hear the sound?
Do you have the sound?
Sound? Can you start it from beginning? Because sound? No? No sound? Okay.
No sound.
Okay. Anyway, this was the surgery, and you can see it on YouTube. But immediately after the procedure, then he said, wait, don't get off. I want you to read. And then he asked for the the bottle of tobramycin there, the antibiotic drop. And then I was able to read the smallest print there. And of course, the audience applauded. You could hear that in the video. So you can watch the full video on YouTube, it's there. And now it's, this was the refraction, post-op at 1 year. Again, I was plus 0.25 in the right eye, minus 1.75 in the left eye. Right eye was 6.3 uncorrected vision, and left eye best corrected was 6 by 4.5, and 5 uncorrected 6.3 and 5. And 10 years post-op, I just got my test before coming here. It's 6.4 N10 in the right eye. Previously it was 6.3 N18. So actually the left eye was, the left eye was N18 and now it's improved to N10, 6.4 N10. Left eye uncorrected was 6.18 at 1 year post-op, but now it's like 6.9 parts. So that's improved. My uncorrected vision is improved, but the refraction is the same. So I'm kind of wondering what's happening there. Maybe it's the brain which is adapted. So minus 1.75 in the left eye. N5, so uncorrected still 6.4 N5. And that's the topography. That's 1 year versus 10 years. You can see there's no difference. The stability is excellent. The cornea is about the same. This is the left eye, again pentacam. Exactly same topos. So intermediate vision also has remained the same. Monocularly left eye is N5 at 60 centimeters, N8 at 80 centimeters. Binocularly N5, 60 centimeters, N6 at 80 centimeters. Stereopsis is 60 arcs. My corrected stereopsis is 20-second arcs. So that's probably the best that it can get. And so Dan, I haven't aged in 10 years. Or at least my eyes haven't aged. So this is the atlas topography, again, the same thing here. So I just wanted to share these details. So it is a very stable procedure, and you can, this is one thing that reverses aging probably.
Well, certainly. So,
I think both are good.
June and Liz, you guys also, anybody else here has had Presbyond? Okay, well, we will take your, we already took a photograph. We know who's wearing glasses. And as you walk out the door, boom, and you're going to get Presbyond. Okay? No, but guys, come up here, because here's an interesting thing. You know, there is this thing about beware of the refractive surgeon who is wearing glasses, right? I mean, it doesn't instill confidence, right? If you're wearing glasses and you're telling a patient to do surgery to get rid of glasses, right? Let's stand up. Oh, here we are. Okay, we should do it with the audience in the background, really. I mean, that would be, that's the rock star way of doing it, right? They take a picture of the audience while we're here. There we go. Okay. Yeah, so just quickly, what's your story?
I had an hyperopic LASIK done 10 years ago, and I'm very quite active. So I've been doing Presbyond since 2018, but because of I'm basically an enhancement case that needs to be done, so I had to get them to help me out to do. And the best thing was at the last forefront, I went in 2024, I had it done during the period. So it's opened up so much. I mean, I don't want to talk about numbers because we all know the numbers, what the perfect numbers, but as a person, you know, as an ophthalmologist, I can now load lens without using the microscope. And, patients, it's easier to sell my Presbyond to the patients because, okay, look, I'm a Presbyond patient. Look, I close my eyes, I can look 6.6 there, and I just take anything on my table, and I still can read it with this eye. This is my far eye. Then I swap over. This is my reading eye. It's super. Look, I can still see the time, what it is there. So it's very easy to sell your case. And I would like pass it to her. She sat next to me during the forefront, and I told her the next day, you have to do it. That's why she got it done as well. So I'll pass it to her. Oh, and also Prof. YG has harassed me throughout so many times asking me about the procedure. So I'm quite happy that he got it done too.
Yeah.
Well, I attended the meeting, the training course in last May in London. Then I heard Professor say he just did his Presbyond before, just 2 days before, and he can see very clearly. And the other colleague from South America, he said he is a professor around 40 years already, and he did the Presbyond during that meeting. And that inspired me a lot because I do plastic surgery before, but I quit it because I wear glasses. I didn't persuade myself to do that because the operation will lose the contrast sensitivity. So I didn't do that. And not bad. I do some early stage about the Presbyond for my patient. I found, wow, that's just perfect. That's why I go to London. Then after they share their experience during the meeting, and then I decided to do that. So I go to London the second time in November. Then I did my Presbyond, and I'm very happy. Only one regret: it's too late.
Do it sooner.
Yes, I should do it. I should do it soon. That's perfect.
Thank you so much. Can we have a big round of applause? Excellent session, and I think all the talks today went to show that it is the procedure today for presbyopia. If the shoe fits, if you're suitable for Presbyond, then it's the safest and most accurate, with excellent results, of course, as you've seen today. So it's something that all of us should adopt in our practices and start off with. Thank you so much, everybody. I would like to thank the speakers and call them out here for a quick picture before we move on to the next session.
Thank you.